Okay, we're going to go to the second P, and that is passageway. And what kind of problems can you have with the pelvis? And then you're thinking, well, you can't exactly go to a pelvic store and buy another one. Yes, that is true. You are stuck with what you got, and students usually ask me, well, would you know by the time you go into labor if it's not going to work, where the baby can't come down, it's stuck in the pelvis? And most of the time, they don't know, unless they look at the ultrasound and see how big the baby is. So you can have contractions of the pelvic diameters and all the different parts of the pelvis, as you can see here, many different reasons. I mean, you can have a motor vehicle accident, and you could be 13 years old. See, there's many different reasons. And all I want to say at this point in time is when we saw the different types of pelvises, I guess it was called, in the labor and delivery lecture, you remember which one that you want. The one you really want is the gynecoid pelvis. It's 50% of all moms that have the gynecoid pelvis. So I want to impress upon you that when the baby does come down the chute and enters the true pelvis, that we want to say at this point in time, just collectively speaking, there's lots of what we call contractures. That means the abnormally shaped pelvis. But the biggest problem is that the baby gets stuck. And sometimes what we have, which is the most common, is the arrest of fetal descent. And we'll talk about that a little bit later. But they'll say in a lay term, when you hear people trying to have a baby, your baby is stuck. Or your baby, stopped coming down. And we know in that terminology is the arrest of fetal descent. So when you see the arrest of fetal descent, that typically means you can do one of two things. And I just want to say collectively, don't memorize this. Collectively say what can be the result. It could be either you can have a spontaneous vaginal delivery with a vacuum extraction. They don't use forceps as much anymore, or a C-section. We'll talk about prolapse cord a little later, but just remember the terminology in all these small or abnormal shaped pelvises is usually the arrest of fetal descent, or the fetus can't come down. And this is the differences. We can either do a vag delivery or a C-section. Let's go to soft tissue of the pelvis. We talk about hard, bony pelvis. And you think, well, there's literally physical or mechanical obstructions of the birth canal. And you're thinking, how that can happen? Sometimes the mom doesn't even know until when she has her first baby. And of course, when we look at the choices here, you think, wow, the most common causes we can say is not so much fibroids, but it's a full bladder. Most of the time, it is a full bladder, and what are we going to do? We're going to straight cath. And if she needs a epidural, we're definitely going to put a Foley in. If she needs a C-section, we're going to put a Foley in. So that will take about care of the most common cause, full bladder. Then it's going to allow the baby to descend and the uterus to contract. So that's all I want to say about pelvis. Now we talk about the passenger. The passenger is not only of course, the fetus, but it's also the placenta. But we want to focus mostly on the fetus here. And the fetus has many different things. We have a lot of them. We have twins, triplets, and quads. You can have perhaps myomeningocele, very big head, of course. So it decreases the rate of fetal descent and expulsion. And huge complications, like we said above, is that the baby can get stuck in many different ways. And the problem is that we only have, now you think about the phases and the stages of labor and delivery, from second stage birth of baby to third stage birth of placenta is about anywhere from 5 to 10 minutes. If you look on that table we had in labor delivery lecture, and you think, wow, it's only about 5 to 10 minutes in a normal delivery. So basically that's what they're saying, is that baby needs to get out before the placenta comes. And you don't want the baby stuck, because if the baby's stuck, right, either in the bony pelvis or maybe some soft tissue, the placenta doesn't know. It's going to start shearing away, because it's due from uterine contractions. That would be horrible. The baby's still in there, and the placenta is separated from the mom. It's still stuck inside the uterus. So that could happen, and then you're going to have injuries. You can have asphyxia. We've got to get the baby out somehow. And that is probably the most critical time, is that baby getting out and then the placenta coming out, not the reverse where the baby doesn't come out and the placenta separates. So what can we have on these babies? I'm going to show you some pictures later on the complications. And of course, you have babies who have tumors, myelomeningocele. We talked hydrocephalus, gross ascites. It'll be very difficult for them to come out. And of course, they need to be what? Identified on ultrasound. That's huge. Prenatal care, prenatal care, prenatal care. It's huge, right? Then the babies can be big. Cephalo, head, pelvic, mom, disproportion, or fetal pelvic disproportion. We kind of talked about that before. Usually a C-section. And these babies are big. They're LGA. And then they can be, we talked about the LND lecture. They can be what? Malposition. OP is not fun. And severe back ache. Because what? Their occipital is pressing against, or hard occipital is pressing against their what? Their sacrum. Hard and flexible occipital, hard and flexible sacrum. So you'll see in the L&D lecture, we talk about counter pressure. We put on hands and knees, get that OP off her sacrum. And some providers actually turn the baby from OP. They actually put their hand in there and turn the baby's head in position from OP to OA. So we are talking about malpresentation, breech, not very high in terms of term babies, 3 to 4%, but 25% because why? Preterms are small. They move around a lot. So we have all these different positions, and we're going to see on the pictures that includes all these different positions. Well, the baby who's born breech is not typically on purpose. A term, breech, birth, vaginally is typically not planned. And the baby does and suffers a lot coming down the chute. So we want to actually talk about breech. Now think of the baby in breech and just picture in your head. And we can actually diagnostic workup. We can do Leopold's maneuver. Remember, you feel the lumps and the bumps. We can check vaginal examination and actually do what? Palpate his buttocks and his anus. We can see it on ultrasound. We notice he descends a lot more slowly than a vertex. Remember, vertex is that little bullet, right? Labor is not usually prolonged. However, the big problems, we're going to learn this a little bit more in a few pages toward the end, that you can have a prolapse cord. Now think about it. His head is on the top. His bottom is on the bottom, right? So when upon ROM, sometimes the amniotic fluid gushes and it pulls out the cord. And the cord pulls out, like loops out a little or a lot. That's a medical emergency because it can be what? Compressed. So that's not good. So they're also worried about prolapse cord on a breech baby upon ROM. That's a huge problem. Mexstain, he doesn't do well with that fundus on top of his head, right immediately on top, and it's pounding on his head. So he stresses out. Meconium stain, amniotic fluid. We find this. Of course, the fetal heart tone, or the heart rate when we pick it up on the ultrasound, is above her belly button, right? It's usually in, we try to get that the ultrasound behind his head or behind his scapula, and it's usually above what? It's either the right or left upper quadrants. So it's somewhere up there. We can do possibly a vag delivery. Usually the babies are small. And we can do versions. And we have pictures of version where we actually go externally on top of her belly and push the lumps and bumps and move the baby from what? From breech to vertex. Typically, they are planned C-sections on most breech presentations. Vag, if we have to with forceps, it's not common. So on face and brow, we can do vag delivery forceps also in C-sections. Also on shoulder, they'll do external cephalic version. We'll try to move the baby from the shoulder transverse leg to, again, vertex. Multi-fetal pregnancies. Well, man, what do you got to do with all these? Well, definitely, we're not going to always, on purpose, we try not to deliver all of them, and we like to primarily want them to go all the way out to as much as we can later, maybe not 38 to 40 week term, but we like to push them out as far as we can, as much as the poor uterus can take. Some babies go out to 34 weeks, which is a miracle, 35 weeks. We keep the bun in the oven, and of course it's getting squishy. And when it's getting squishy, they can do one of two things. Not only, of course, a vaginal section, they can try to internally turn the babies. It's called an internal version, where we can actually, practitioner or provider can put his hands in there and turn the baby's head down. Or they can do, on top of that, an external cephalic version where we go on top and turn the babies. Typically, babies are multi-gestation, are born early, they're small, and for some cases, you might see one comes out vaginally, another one comes out C-section. So the poor mom has both routes done to her. And associated with many different reasons. There is a maternal, and you're saying to yourself, well, all this kind of like overlap, because we've already talked about all this before. That is true. Maternal position, a fourth P, the position that alters the effective gravity and the relationships among body parts. And we talked about this in labor delivery, how hands and knees help going from OP to OA. Sitting and squatting increases fetal descent, shortens the second stage, and what? It also avoids supine hypotension, right? There's no pressure on the great vessels. Most moms are delivered what? Unfortunately or unfortunately, I don't know how you want to see the advantage or disadvantage, is recumbent or lithotomy position, the low Fowler. So what? That reason why the provider has more control of the delivery, but then not the best what? For gravity. So we're seeing more dystocia, forceps or vacuum extractions, and C-sections. The fifth P is psychological, related to past experiences, culture, heritage, support systems. Sometimes it can prolong the labor and also increase perception of pain. All right, let's go to abnormal labor patterns. Abnormal labor patterns, you always have to remember, again, I'm going to say it one more time. Right up here. Contraction should be coming every 2 to 3 minutes with a strength of 50 to 80 millimeters per mercury. It should be severe, and the duration is a minute to minute and a half. And also we're going to talk about the labor curve. Now in the L&D lectures, in normal unit 1, I showed you the labor curve. And we usually say about 8 to 10 hours it takes for moms to deliver. And just thinking unit 2, everything except normal, right? So there's lots of reasons why we do not have the normal labor curve. We'll just say it that way. Even like you can say, oh, well, it makes sense. All of this overlaps. She's stressed out. She's anxious. She has epidural in. It slows it down. Maybe the pelvis is abnormally shaped. The head is too big. She has sepsis. She's dehydrated. Complications. She's ruptured. So I want to say in this area, prolonged means and protracted are the same thing. Why would things in terms of the labor curve or her labor be long? And we talk about the stages here, and this is talking about what we call the stationing or the descent. The question is, don't get caught up in all the terminology saying, why would the phase, like from latent to active, be long? So you're saying why? And then you're going to see this in a lot of charts. Either latent or active phase are long, and they're going to write in the chart due to secondary arrest. And there's no changes in the phases. This is what happens. And then, of course, the nullipars and the multipars, they're waiting more than 2 hours long. It's a long time. So you're going to see these moms who, it says in her chart, C-section due to secondary arrest. The phase, latent phase, just stopped. Active phase, remember, latent 0 to 3 centimeters, stopped. Active phase is 4 to 6 centimeters, dilation stopped. So when we look at the phases, we're looking at dilation. Now we're looking about descent. We're talking about stationing. And so why does the baby stop coming down? And when he just arrests, it's called failure of fetal descent, or failure of descent. And you're going to see that on the moms who had C-sections. So there's many things that can slow down. Cervical dilation, which is defined by the phases, and the descent. The lastly is precipitous labor, when she goes super, super fast. Now, all I want to say in the last part before we get off is the precipitous labor is important to know. So we'll look at this next video.